بسم الله الرحمن الرحيم. النهارده هنتكلم عن المحاضرة الثانية في السيرجيكال انفكشنز. هنتكلم عن الاكيوت سبيسيفيك سيرجيكال انفكشنز اند كرونيك سبيسيفيك سيرجيكال انفكشنز. بالنسبة للاكيوت سبيسيفيك سيرجيكال انفكشنز هنتكلم عن موضوع التيتانوس، الجاز جانجرين والنيكروتايزنج فاشيتس. بالنسبة للتيتانوس، tetanus is a specific infection mediated by the neurotoxin of Clostridium tetani, which is a gram-positive anaerobic spore-forming bacilli. Infection occurs via wounds where the positive organism enter and flourishes in hypoxic wounds contaminated with soil or feces. Another mode of infection is through the umbilical stump, and this is tetanus neonatal. Regarding the pathology, the neurotoxin reaches the CNS, and there it becomes fixed by motor cells, and these toxins increase the excitability of motor cells in the medulla and the spinal cord. Clinically, in the incubation period, the patient is restless or anxious. There is tenderness, swelling at the site of the wound, local twitches, and rigidity of the nearby muscles. In the tonic stage, there is limitation of movement of the jaw, spasm of facial muscles, and later there is neck stiffness, difficulty in swallowing, and laryngeal spasm. In the clonic stage, there is reflex paroxysms of violent muscular contractions. The body may be arched backwards. There is, in late stages, there is a spasm of respiratory muscles, which may lead to appearance of apnea. The differential diagnosis of tetanus is trismus, meningitis, strychnine poisoning, tetany, and thrips. Prophylaxis against tetanus is made by active immunization and passive immunization. Active immunization using the tetanus toxoid, and passive immunization is by tetanus immunoglobulin and the anti-tetanic serum. The treatment is by isolation in dark white room, tetanus immunoglobulin in order to neutralize the toxins, aqueous penicillin to kill the organisms, excision of suspected wound, Valium to control spasm and convulsions, and intubation mechanical ventilation if respiratory problem occurs. Gas gangrene is an acute spreading gangrene associated with gas formation and profound toxemia. It occurs due to infection by Clostridium falciei, and this is an anaerobic spore-bearing bacillus. The factors predisposing to gas gangrene are extensive lacerated wounds involving bulky muscles, presence of foreign bodies, ischemia of the muscles, infection by aerobic bacteria, and also it may follow above knee amputation. Regarding the pathology, the Clostridia invade the tissues, proliferate, produce toxins which induce muscle necrosis, fermentation, gas production, and generally it causes hemolysis and mild jaundice and degenerative changes in the liver, kidneys, and adrenals. Clinically, generally, the patient is anxious, pale, with jaundice, there is fever, marked tachycardia, urine output is decreased, and in severe cases, the patient is shocked. Locally, the patient complains of numbness in the affected limb, and the limb is swollen with crepitus, gas bubbles, overlying skin shows black discoloration with blips of foul-smelling dark fluid. The differential diagnosis of gas gangrene is infection by other gas-forming organisms and surgical emphysema. Gas gangrene is prevented by 4 severely lacerated and contaminated wounds, by wound debridement, and by antibiotics and circulatory support. When gas gangrene occurs, the treatment will be by wound management. All the necrotic tissues and deep muscles and the dead muscles are adequately excised. The wound is left open, and sometimes amputation of the whole limb is required. Also by antibiotics, hyperbaric oxygen, and proximal divergent colostomy may be needed if there is perineal wounds with injury of the colon or rectum. And this photo show the wound management where all the necrotic tissues and dead muscles were adequately excised and the wound is left open. Necrotizing fasciitis is an invasive infection which is caused by a mixture of staph, streptococci, and gram-negative bacteria and anaerobes infection. The microbes gain access via a puncture wound, a leg ulcer, or a surgical wound. The infection is more likely to occur in a diabetic patient with malignancy, and other patients which are immunocompromised patients. The infectious process spreads along the fascia trains and causes thrombosis of vessels, hemorrhagic skin bully, fascial and subcutaneous fat necrosis. Generally, the patient is alert and conscious, but with manifestations of toxemia, like fever, tachycardia, and so on. Locally, the skin shows hemorrhagic bully and necrosis, and the affected part is edematous, and cryptus is occasionally present. Prevention of necrotizing fasciitis is made by adequate debridement of lacerate and contaminated wound. Blood loss is replaced, antibiotic is given for contaminated wounds. And the treatment is by surgical excision of all necrotic skin and fascia. And we should notice in this situation that the muscles are not affected in this problem. Antibiotics, anti-gram positive, anti-gram negative, are given, blood transfusion, nutritional support, and control of diabetes. The chronic specific infections, the items in this issue is tuberculosis, syphilis, and actinomyces. Tuberculosis is a chronic specific infection caused by the tubercle bacilli, which is a gram-positive acid-fast bacilli. The mode of infection is by inhalation, ingestion, or direct inoculation. The characteristic lesion of tuberculosis is the tubercle, which consists of epithelioid cells, lymphocytes, Langerhans giant cells, and clumps of the bacilli. The fate of the tubercle depends on the resistance of the host. It could pass into caseation, which is coagulative necrosis, or fibrosis and calcification with high resistance of the host. The spread of tuberculosis occurs by direct, lymphatic, by blood, or via natural passages. Clinical picture, there is systemic manifestation in the form of TB toxemia, loss of appetite, loss of weight, night fever, night sweats, and tachycardia. Locally, there is lymphadenopathy, and at the beginning, the lymph nodes are solid and clinically discrete. Cold abscess occurs when there is caseation of the lymph nodes, forming this cold abscess, which lacks the signs of acute inflammation unless there is secondary pyogenic infection. TB sinuses follow a rupture of deep abscess. Usually, they are multiple and surrounded by tuberculous ulcers and unhealthy scars. The tuberculous ulcers has a regular outline, undermines cyanotic edge, and deficient anemic granulation tissue in the floor. And this is a summary of the natural history of tuberculous lymphadenitis. First, from the primary focus to the lymph node, making the solid lymph nodes clinically discrete, then caseous lymph nodes, clinically matted mass, and then collar stud abscess, and then tuberculous sinus. Investigations for tuberculosis include bacteriological examination for T. bacilli, tuberculin test, PSR, X-ray of lungs or kidneys. Biopsy may be needed to establish the diagnosis. The treatment is by improving the general condition of the patient by tonics, vitamins, good diet, and air, by systemic antituberculous drugs, and locally by repeated aspiration of the cold gases. Syphilis is a sexually transmitted disease caused by the spirochete Trichonema pallidum. Congenital syphilis affects the fetus by transplacental spread from the diseased mother, while acquired syphilis is transmitted by intimate sexual contact with an infected person. Primary syphilis affects the genitalia, lips, and tongue, and it presents by an ulcer, which is called chancre, with enlarged draining lymph node. Secondary syphilis, the presentation is by widespread rash and generalized lymphadenopathy. Tertiary syphilis, the presentation is by a firm rounded mass, enlarges slowly and softens at the center. This is the gamma. Gammatous ulcer has a circular outline, punched out edge, indurated base, wash leather, slough at the floor. Actinomycosis is a granuloma which is caused by an organism which is called Streptothrax actinomyces of Israeli, a gram-positive anaerobic filamentous bacterium, which is a normal flora of the oropharynx. And in most cases, it gets access to the tissues through abrasions in the mucous membrane. Some cases, the lungs are infected by inhalation, and rarely the skin is invaded by direct inoculation. Pathologically, the disease is characterized by inflammatory nodular mass, which may liquefy to form abscesses and sinuses. And the characteristic feature is the presence of sulfur granules in the tissues and the pus. This is a small yellowish granules, and actually it is a colony of the organism. Clinically, there are several areas affected by this condition. Tissue cervical type, 60%, hard nodular painless mass in the parotid region. When softening and formation of abscess occurs, sinuses will form, discharging the pus and sulfur granules. The second site is the abdominal type, forming an indurated mass affecting the ileocecum, later invade the abdominal wall, resulting in multiple sinuses. The liver is occasionally affected by blood spread from the ileocecum or direct from the chest. The third place is the thoracic type, 15%, usually occurs by aspiration of the organism from the oropharynx, and it presents by cough, pleural pain, fever, weight loss, later by chest wall and sinuses. Cutaneous type, the skin is rarely affected by direct inoculation. The treatment of actinomycosis is by penicillin, and surgery could be required for excision of affected skin, like in this picture. So, specific surgical infection could be acute or chronic. Acute specific surgical infections, tetanus, gas gangrene, necrotizing fasciitis, and the chronic specific surgical infections. The most usual types are tuberculosis, syphilis, and actinomycosis. Thank you.